Welcome back to part 2 of long COVID pain in the joints and also the muscles. So, as before, I'm Dr. Tim Robbins, formerly a family doctor for 30 years, now Long Covid Services for 5 years. I'm posting on podcast channels and YouTube. I hope you find them helpful. And if you like them, click subscribe, spread the word. I have to add my usual disclaimer. Any advice or treatment I mention should only be considered after talking to your own doctor. So, part 1, I talked about muscle and joint pain in long COVID and the causes, what the patients are experiencing, you patients are experiencing, as well as the explanations, the causes behind them. Here, now in part 2, I will talk about how we're going to tackle them. So, a quick recap. As I said, in part 1, I focused on muscle and joint pain. I know that there are other areas that you can have pain, so headache and chest pain. Well, there are podcasts for those as well. I told you what, you're experiencing, not that you need me to tell you, but the effects on your lifestyle. And I covered the causes. And remember what the causes are? Basically, inflammation of the tissues, that's the joints and muscles themselves. Inflammation of the nerves, the pain fibers going to the brain. So the vagus nerve, that's the sensory part of the vagus nerve, and the small fiber nerves around the body, and how they get affected and damaged and lead to small fiber neuropathy. And then there was inflammation and dysfunction of the pain center itself in the brain, in the basically that area in the hindbrain, that the brain stem, that all those autonomic processes are basically focused. So, those are the causes. But the end result, of course, is pain. Pain from the tissues, what we call nociceptive pain, and pain from the nervous nerve fibers, neuropathic pain. And when these, like I said, in the part 1, basically, if that pain is long-lasting, prolonged, it leads to chronic pain. Basically, if it's there for more than 12 weeks, 3 months, that's now chronic pain. And that is because of central sensitization. Remember, the pain fibers are overexcitable, oversensitive. The pain fibers are firing when they shouldn't do, okay? And it's permanent, it's fixed, and it's sort of an abnormal pain response, chronic pain, as I said. So, how are we going to tackle muscle and joint pain in long COVID? Well, first and foremost, medication, so drug treatments. Well, any painful area, remember back to how it was prior to getting COVID, long COVID. If you had a painful joint or an achiness somewhere, what did you do? You took a painkiller, be it a simple analgesic such as paracetamol. Okay, that's still valid. Yeah, as long as you don't exceed, regular paracetamol for more than 15 days of a month. So, in other words, 2 weeks, 2 out of 4. If you don't exceed more than that, paracetamol is still an excellent painkiller. The reason I say don't exceed more than that, because basically the regime for paracetamol is 2 tablets 4 times a day, isn't it? So 8 a day. If you exceed that for more than 4 weeks, for more than 15 days, then you can have what we call analgesia overuse pain or headache. Okay, so in a way it backfires a bit, but basically paracetamol is an excellent painkiller. It may be sufficient to address your muscle and joint pain. However, a non-steroidal anti-inflammatory drug would probably be more specific for joint pain and probably muscle pain as well. So ibuprofen, 400 milligrams, 3 times a day. Remember, not on an empty stomach because it can cause gastric irritation. I don't want you to have indigestion, an ulcer in your stomach or your duodenum. So, anti-inflammatory anti-inflammatory tablet, ibuprofen. The next group of medications that are used for chronic pain are a group collectively anticonvulsant drugs, but not because you've got convulsions or seizures or epilepsy. This group of drugs actually has been found to have inhibitory effects. They are inhibitory neurotransmitters. So they inhibit nerve passage in pain fibers, okay? So the ones that are most frequently used and indicated in chronic pain, and particularly in chronic pain such as in fibromyalgia, is pregabalin. The other one is gabapentin. These are very good for dealing with nerve pain. They're not as effective for pain to do with arthritis in the joints, for example. But, nowadays, in pain world, chronic osteoarthritis pain does have an element of central sensitization in it. So therefore, you could say that those two drugs, pregabalin and gabapentin, may well be of use in osteoarthritic degenerative joint disease pain as well. The only thing to watch out for with this class of drugs is that it can lead to dependency. So you can become, if you like, dependent on them. So this is a drug that you can only get from your doctor on a prescription. The doctor will be, hopefully, monitoring your usage of this and basically sort of tailoring the dose to the need and discontinuing it when it's not needed. So that's the second group of drugs. Or third, really, we've had paracetamol, so simple analgesics, we've had anti-inflammatories, and these anticonvulsant ones. Like I said, not because you've got convulsions or epilepsy or seizures, just because they are they inhibit neurotransmission, put nerves to sleep, if you like. And then the fourth group is the antidepressant group. Okay, again, same caveat. It's not because we think that you're depressed. No. Because this group of drugs also has nerve depressing, I was going to say. It suppresses nerve impulses. So particularly, there's the old-fashioned one, a tricyclic antidepressant, amitriptyline, which has been around for donkey's years. But like I said, if you are prescribed this, and you look at the drug sheet and say, it says it's an antidepressant. He thinks I'm depressed. She thinks I'm depressed. No, it's not because of that. None of us use that amitriptyline anymore for depression because there are much cleaner drugs and much more effective drugs now. Much cleaner in the sense of no side effects. So amitriptyline's side effect is, apart from dry mouth and can cause sort of bladder retention, urine retention, is sedation. So yes, we use it for neuropathic pain, for central sensitization pain. 10 milligrams at night, very effective. And you can go up to anything up to 50 milligrams, but anything beyond, say, 20 milligrams at night can lead the patients, and I've seen this in lots of patients over the years, they sort of report back and say, look, actually it feels like next morning I've got a hangover. I just can't function properly. I still feel half asleep. So that sedation effect can obviously become more of a problem at the higher dose. 10 milligrams very infrequently causes sedation the next morning. So it's a good sleep enhancer as well, obviously, which is good for long COVID. A lot of long COVID patients have sleep disturbance. So it's not only good for pains, but also for sleep enhancement. So that's the, if you like, in this category, the antidepressant category, the drug we use initially, because it's tried and tested and is safe. There's another class of drugs that is now used in the antidepressant class that is now used. They are called the SNRIs. So serotonin norepinephrine reuptake inhibitor drugs, of which duloxetine is the most commonly prescribed. And it's got a license for treatment with fibromyalgia and neuropathic pain, and hence central sensitization pain. And it's got specific action activity on sort of nerve transmitters also. So that is certainly a drug that is in our sort of armamentarium for treating chronic pain anywhere. So those are the 4 groups of drugs that we can prescribe for chronic pain in the joints or in muscles. You may well have heard of low-dose naltrexone. Low-dose naltrexone, LDN. We have a number of patients who are doing their own research, and if I had long COVID, I would be doing my own research. I would want to do everything in my power to try and speed up my recovery. So there's a lot in the in the long COVID community talking about LDN. LDN, low-dose naltrexone. Naltrexone is a drug that's been around for donkey's years, and we use it to reverse so opiates, morphine. If you've had too much of a morphine, it can reverse the effect of morphine, and so off the back of that, it is used in conventional medicine for helping patients detox from opiates. So, but that is in a high dose. That's 50 milligram dose. Okay, that's not what we're talking about here. We're talking about low dose, 5 milligrams, and they talk about what's known as a hormetic effect. So in high dose, it'll produce one set of symptoms. In low dose, it'll produce a different set of symptoms, the opposite set of symptoms. And in low dose, what we find is that it's not only an analgesic, painkiller, so pain relief. This is why our long COVID patients with pain and general pain and muscle and joint pain are asking for it. But also, it's got an interesting property of being an anti-inflammatory. So it basically tones down the cytokines. So it has a dual action, this both analgesic and anti-inflammatory. So it seems like, therefore, the ideal drug to have for long COVID. However, I have to say, it's not in the NICE guidelines for management of long COVID, NICE being the National Institute of Clinical and Health Excellence. So these are the guidelines we, the doctors, adhere to provide the best evidence-based medicine and treatments that are backed up by research and safe. So it's not in the NICE guidelines. For that reason, we don't we don't prescribe it. So really you can't get it on the National Health Service. Some people have been buying it online, and if you're considering this, obviously talk to your doctor about it. I don't think the doctor will be overly encouraging. However, it's your choice, but beware. Anything you buy online, just make sure that what you're getting is what's on the label. It's not just basically powdered chalk or what have you. If you want to know more about low-dose naltrexone, look up the website is ldnresearchtrust.org. I'll say that again, ldnresearchtrust.org. Okay, then you'll have a very balanced view on it. But like I said, if you then read it and think, I'd like a bit of that, actually your doctor won't be able to prescribe it or won't be willing to prescribe it. How else can we tackle pain though? Pain with muscle and joint pain in long COVID. Well, what I'm going to tell you now are all backed up by research studies. Basically, physiotherapy, sort of gentle manipulation can help. So osteopathic manipulation also. Acupuncture for those muscles with, particularly for patients who have trigger point pains and also around joints. So acupuncture, there's, as you probably know, there's Western acupuncture and Eastern acupuncture. Western acupuncture is what we describe as dry needling acupuncture, hopefully by practitioners who know their anatomy, etc. So we'll be sticking their needles where in the painful parts where there's no other clockwork, no other nerves and blood vessels, etc. So Western acupuncture. And when I was in general practice, I did quite a lot of Western dry needle acupuncture. So I was the pin man, as one patient said, called me once. With these patients who have trigger point pain, classically over the neck, over the back, the upper back, and the shoulders, and sort of the base of the neck, trigger point needling is pretty effective at basically releasing that pain, releasing that tension in those bands of muscles. So that's physio, manipulation and acupuncture. Then there's the talking therapies. Again, this is backed up by research studies. So there's two. There's CBT, cognitive behavioral therapy, which basically changes the way you think about pain. Okay, well that, like I said, studies to demonstrate that actually makes an improvement to patients' pain perception. The other is ACT, which stands for acceptance commitment therapy, which again helps you deal with negative thoughts towards pain. As I said, these are all backed up by sort of research studies, placebo-controlled, double-blind, placebo-controlled trials. So those are the sort of other, if you like, other strategies that you can employ for pain, muscle, joint. But then there's the general recovery, to reduce the inflammation. Remember, in the causes, in part one, I talked about the causes being inflammation of the tissues and the joints, inflammation of the nerves that carry those pain impulses up to the pain center, and the inflammation in the brain. But, basically, as we know, long COVID is inflammation all over, isn't it? How are we going to combat that? How are we going to combat that? How are we going to reduce that inflammation? Well, just think of a number of strategies. One is the diet. Again, a mixed, balanced diet, a Mediterranean diet, a diet that contains polyphenols, those naturally occurring substances in plants. We talk about eating the rainbow, don't we? all the different spectrum of colours for the fruits and the veg. Because the rainbow is all to do with the different type of polyphenols that there are in each fruit. So blueberries, its polyphenol is different from raspberries. Blue versus red. So if you can get as many as possible, many different polyphenols as possible in there, in your diet, then they're all going to contribute to that anti-inflammatory effect. A mixed balanced diet will also provide you with what's known as prebiotic fibre, which basically nourishes your gut microbiome. Okay, and a healthy microbiome, your friendly bacteria in your large intestine I'm talking about, one of their many functions, apart from supporting the immune system, so therefore helps your attack inflammation, is also the creation of neurotransmitters. So neurotransmitters being those chemicals that are concentrated in the brain and work towards harmony of all the different nerve centers in the brain, bring about that balance. So serotonin, for example, if you like, the antidepressant neurotransmitter, dopamine, GABA, these are all neurotransmitters that are created in the large intestine. So therefore you've got to have, by the microbiota, friendly microbiota. So therefore let's feed the microbiota so that we have as a healthy population of them as possible to do their good work. So that's the diet sorted. Then there are, supplements. You can take supplements. Well, a lot of people do take supplements, don't they? So is there rationale behind this? This is all evidence-based medicine that I'm going to be able to now tell you about. So the antioxidants you can take, so vitamin C. You can take N-acetylcysteine, which is basically a cofactor it has antioxidant properties. CoQ10, which again has antioxidant properties. It is part of what we call the energy creating cycle in mitochondria. So it actually you can have its benefits for that as well. And then omega-3 fatty acids, those fish oils from the oily fish, salmon, mackerel, sardines. So omega-3, you can take it as a supplement if you can't have or don't like to take two fish meals a week, which is said to be the amount that you need to get you the sufficient intake of omega-3. But you can also get omega-3, incidentally, from flax seeds. So those are the sort of the antioxidants. Omega-3 is an antioxidant as well. It dampens down inflammation. Then you've got the herbal preparations. Again, they provide you with polyphenols. I've talked about polyphenols already. I've talked about the rainbow in your diet. So the polyphenols, quercetin, picaregenol, and turmeric. So again, these are all evidence-based. They show a benefit. Not very strong, but certainly do show a benefit. But they are anti-inflammatory. So quercetin is the commonest of them. It's what's known as a flavonoid. Picaregenol so quercetin is in sort of the skin, the peel of all of your fruit, and also in veg. Picaregenol from the bark of a pine tree, maritime pine tree, is a group of polyphenols called the anthocyanins. And then you've got turmeric, again from the Indian subcontinent, contains curcumin. It's from the ginger family, and that also is anti-inflammatory. So, supplements. Just one note. Beware the stack of supplements. You could sort of go into the health food shop and I'll say a bit of this, bit of that. I'm going to have the omega-3 and my quercetin, and you end up walking out with about 8 different supplements and an empty wallet. So what I would say, what I always recommend is taking one at a time and see whether it makes a difference. If it does, ask yourself that question, have them for like 3-4 weeks, then ask yourself that question, am I better, worse, or exactly the same? If I'm better, you're probably going to want to carry on with that supplement. If you're worse, obviously you will stop it. And if you're exactly the same, actually it's not made any difference, so you probably want to discontinue that supplement. So just run them one at a time, okay? And find one that works for you. Just work through. As I said, I don't want to basically load you with supplements. Other caveat is that actually, of all the things that I've mentioned there, you're going to get them from a mixed balanced diet anyway. Vitamin C, obviously, from your fruit. NAC, N-acetylcysteine, from protein-derived foods. Quercetin, from all your fruit, etc. Turmeric, if you're a regular curry eater, you're going to get turmeric. So there we are. The other 2 things that will help towards dampen inflammation are healthy sleep, recuperative, restorative sleep. So remember sleep hygiene, basically no screens on your phone or your tablet an hour before going to sleep because they emit blue light, which is arousing. And then, some people will take melatonin, which you can get online, which is sort of the synthetic version of the natural hormone that we all have in us, in the pineal gland in the brain, which is our natural sleep enhancer or sedative, if you like. It's only released in the dark, which brings me to the importance of having blackout curtains or eye visors, because basically when there's blackout, then your pineal gland will be squirting out melatonin. And incidentally, melatonin is an antioxidant as well. Antioxidant, anti-inflammatory, so it'll help towards that inflammation in your tissues, your joints, your muscles. And finally, in a way, just to round it off, thinking of the holistic whole body sort of approaches, the mind-body strategies. So anything that's going to calm the mind will calm the body. And so therefore, if you like yoga and mindfulness, again, these are backed up with tons of studies, research respected, published in journals, respectable medical journals, that demonstrate that mindfulness and yoga help towards just calming the brain, if you like, but we know that there is a link between the brain and the body and the tissues and the proper immune system. So if you like, nice and calm and focusing on the now, not worrying, about the future or depressed about the past, then these strategies, mind-body techniques, will help you towards general improvement. So, been through the treatments. Having said all that, actually, like I said at the start, with what the GP does when the GP sees you initially, they may at that point think, you need to see a specialist. Like I said, a rheumatologist might be needed, a joint specialist, if you like. Okay. So for those joints that are really severely hot and swollen, okay, because there may be a need for a DMARD. What is a DMARD? DMARD is a disease-modifying anti-rheumatic drug. Now, there are 2 types. There's the sort of, if you like, the conventional DMARD, which is sort of the old-fashioned broad-spectrum immunosuppressant like methotrexate. And then there's the more more up-to-date targeted DMARD, the biologics that, if you like, target a specific single pathway in your immune system. You may need a DMARD if your joint is that angry, inflamed, and having a massive impact on that joint functioning. If the doctor, or from what I've said, makes you wonder whether you might have fibromyalgia, in a way you need referral to a rheumatologist in order to have a diagnosis confirmed of that condition, which then would probably lead to referral on to the chronic pain service for management of this tricky condition, fibromyalgia. And finally, the final reason to go to a rheumatologist is if you suspect that you've got hypermobility. This condition, this Ehlers-Danlos syndrome, like I said, a genetic fault in the formation of collagen tissue, collagen protein tissue in the joints and the muscles, which is, as I've said, is associated with fibromyalgia and ME/CFS. In order to get that diagnosis, you probably need to see a rheumatologist in order to therefore have it managed by the appropriate service, which is the chronic pain service. So there we are. Those are the sort of things the strategies that we can, treatments we can tackle long COVID muscle and joint pain with. Along with all that, I think we've just got to keep in mind that, and this applies to long COVID overall, doesn't it? We need to give it time. I mean, it's called long COVID for a reason. It is long, and it does take a long time to get over. Okay, so it takes time for those nerves. I've said damaged nerves contribute to pain in long COVID. Okay, it takes time for those nerves to be replaced, regrown, repaired, reconnected. This concept of something called neuroplasticity. Okay. It also takes time for muscle cells to be replaced and renewed. So, with cells that have been damaged, destroyed, they will be replaced, but it takes time. So it takes time for them to be replaced and for the numbers to come up. Therefore, more cells, therefore more mitochondria, therefore less lactic acid. It takes time for inflammation in joints and muscles to settle, So with time, with the inflammation settling, there's going to be less pain receptor activation. And it takes time for dysautonomia to settle. This imbalance of the autonomic nervous system, the automatic nervous system, the sympathetic nervous system, and the parasympathetic nervous system. With everything else, it will settle with time. And there's it's been out of kilter, out of balance, but it takes time for the dysautonomia to settle and for that balance to be balanced again, to be returned. And then reconditioning, again, if you've got pain in the joints and the muscles, then you're not going to be as active. Anyone who's not active basically becomes less conditioned. Your muscles and joints are not in such good condition, are they? So, with the reconditioning, we need gentle activity, guided by our fatigue advice, how to manage fatigue. See the podcast, how to manage it. Use the 3 Ps: the planning, the pacing, the prioritizing, in slowly building up in what you can do on a sort of each step-by-step, stepwise process. Small incremental increases, and with each increase, stop, wait, how am I? Better, worse, exactly the same. If I'm worse, that's post-exertional malaise, isn't it? Help, stop, go back to the last step, etc. So reconditioning by that incremental, slow increase, considered increase each time, or not. Hold it, wait, maybe go back, maybe go forward, don't know, wait and see, is the way we should be managing this. So there we are. The update on basically pain in long COVID, muscle and joint pain in long COVID. I hope you found that helpful. As I said at the start, this is an educational series for long COVID sufferers. But remember, my usual disclaimer, any advice or treatments I've mentioned, please discuss them with your own GP. If you found this helpful, please click subscribe. You know, it's a bit of a cliche now. They always say it on YouTube, don't they? Anyway, the idea is spread the word. I want as many long COVID patients to hopefully learn from my podcasts and postings on YouTube as possible in order to help their recovery. Just to say thanks for all the feedback I received, which is a lot. Apologies, no replies. I just don't have the time. I appreciate them though, all the same, because they help me with my future postings. So, in the meantime, I wish you well, and I hope that this has been of help for you. So, all the best then.